screen, and I'm hoping you can hear me very well. Can I confirm that the Madimeja, can you hear me? Perfect.
Can you hear you very well?
Perfect.
Yes, we can.
Wonderful, wonderful. Yeah, welcome and to this Pharmacy Month's webinar. September is Pharmacy Month, and this year's theme is Pharmacy United in Promoting Healthcare for Patient. I am told that we are streaming this live on Facebook and YouTube and also on Teams. So I want to welcome everyone who made time to listen to us tonight as we celebrate this. Pretoria is beautiful and warm. I love summer, and I hope most of us in Pretoria, we do. I'm hoping in all the other provinces, not summer, but I'm hoping in all other provinces it's warm as we celebrate this spring. Okay, back to the reason we are all here. So just some few announcements, the official posters and pamphlet in all 11 official languages and one other language spoken in South Africa, Quidam, are available for download on the websites. They are displayed. I'm sure we can all see them. Or you can follow the QR code displayed on the screen, on your screen, to download the material. Stakeholders are reminded that hard copies of the literature will not be provided. However, the literature available on the website is of print quality and therefore may be printed. Pharmacists are encouraged to disseminate material and educate the public on the role of pharmacists in primary care services. The pharmacy profession is urged to use the Pharmacy Month to promote the role of the pharmacists in the community and visibly demonstrate what the profession can do in the healthcare sector. With that being said, I want to welcome our first speaker, Professor Haneli Meyer. I come very far with Professor Meyer, and I'm so glad to introduce Prof. Meyer. Now, the topic that will be covered by Prof. Meyer is the role of pharmacists in increasing vaccination uptake in communities. And for those of you who don't know Prof. Meyer, I'm going to share a little bit about Haneli. Now, Haneli is a pharmacist by profession, professor in the School of Pharmacy at SMU, and head of South African Vaccination and Immunization Center at SMU. She collaborates with researchers across Africa and internationally, specializing in vaccine safety, vaccine hesitancy, vaccination as an important pillar of antimicrobial stewardship, and the rational use of medicine. Her research aims to strengthen healthcare services, improve public health, and contribute toward reaching the Sustainable Development Goal of good health and well-being. Prof. Meyer chairs the Ministerial Advisory National Immunization Safety Expert Committee and serves on the National Advisory Group on Immunization and the board of the South African Product and Regulatory Authority, what we all know as SAHPRA. She has a passion for community engagement, and in response to the COVID-19 pandemic, she worked with the National Department of Health, SAHPRA, to establish the COVID-19 Vaccine Safety Surveillance Network for South Africa. With those few words, Haneli Meyer, we are in your hands, and thank you.
Good evening, and thank you very much. Let me share my screen. Can you indicate, Moju, that you guys can actually see the full screen?
Yes, Prof.
Okay. So you don't see the note pages, no, you do see the full screen.
Yes, full screen.
Okay, that's good. I don't know whether I can actually switch on my video just for a few minutes. I don't know if you can see me. I can't see myself at this point in time. But yes, thank you very much for the opportunity to present here tonight. So in the interest of bandwidth, I know lots of people have load shedding at this point in time. I will switch off my video while I'm presenting. Good. So yes, as I said, thank you so much for the opportunity to present here tonight. And this is one of my passions. So I am looking forward to, share with everybody. And I hope to inspire pharmacists. And if I say pharmacists, I mean all pharmacists, community pharmacies, pharmacists, hospital pharmacists, and academic pharmacists, to make an effort in terms of increasing the uptake of vaccines. So we will be looking at 4 main questions, and I'll start off with the first one in terms of where are we now with the uptake of vaccines. So firstly, we all know that vaccines are safe, and vaccines save millions and millions of lives every year. At the moment, 4.4 million, and this number is actually going to increase if we are able to reach the immunization agenda of 2030. But the sad news is that 1 in 5 children today are zero-dose children. It means those children have not received a single one of the vaccines within the schedule. 1 in 5 children have no protection against measles, and 7 out of every 8 eligible girls are not vaccinated against HPV, and HPV is there to protect against cervical cancer. Also, the number of children who missed their vaccination increased significantly during the COVID-19 pandemic. Now, UNICEF released this report earlier this year, and it showed that confidence, people's confidence that vaccines are important for children, dropped after the start of the pandemic. And as you can see here on the right-hand side, South Africa is very far down on this list. So the data showed that there was a 30% decline in confidence in childhood vaccines in South Africa among South Africans. And we are now sitting at only 62% of the population believing that it is important to vaccinate children. So let's look at the situation in South Africa in terms of the uptake of the EPI scheduled vaccines between 2018 and 2022 on this screen, on this slide. So as you can see, what I want to point out is that the target for fully immunized children of the World Health Organization is 90%. And the target... Yes.
Just hold on a moment. It seems that some of our audience cannot see the slides. We just want to sort it out. If you can just give us a minute or two, okay. I'll let you know when we can continue. Apologies for that.
Okay, then. Should I perhaps stop sharing and share again?
Prof. Meyer, it seems that on our side it's fine. It may be a load shedding issue. So we did post a message on the chat if people can maybe also join via the YouTube link. I think it's maybe a bandwidth problem on the audience side.
Yes, because you can see the slides. No.
Yes.
Okay. Should I continue?
Please continue. Thank you, Prof.
Okay, good. So what I said is that I want to point out the targets here on the right-hand side in red So for measles, we need a 95% coverage to prevent an outbreak. And as you know, we had a serious outbreak this year. And as you can see from these figures, we are way below the expected targets. Now, on this slide, you can see the data on the zero-dose children. And this is what we will be focusing on now in future. So on the left-hand side, it's the absolute numbers, and on the right-hand side, it's the percentage. So if you look at 2022, we now have 13% of zero-dose children. So 13% of the child population in South Africa has not received a single dose of any of their scheduled vaccines. So this is very serious, and that is where our energy and our focus should now be moving forward. Now, I also want to point out in terms of HPV vaccination. So here you can see the official HPV vaccination coverage by the age of 15 years for South Africa, as it's been reported annually through the WHO UNICEF joint reporting form for 2020, 2021 and 2022. So what you can see here also, the target is 90% of girls should be fully vaccinated by the age of 15 years. And by 2030, that is the WHO target. And as you can see, we are also not reaching that target yet, especially in terms of the second dose. Also bear in mind that the HPV vaccine currently is only offered free of charge within the school health program for public sector girls. And cervical cancer is currently the leading cause of female cancer deaths in South Africa, especially in the 15 to 44 years age group. So this is also something that we need to focus on moving forward, also in terms of getting the private school girls to also receive the HPV vaccine within the program. So on this slide, you will see the vaccination utilization for the influenza vaccine. So what I want to point out, this is the data for last year. So the estimated utilization by the end of the year was 75%. So it means that 25% of the doses that we received in South Africa was actually wasted. On the right-hand side, I just want to point out, of those doses that we have used, only 9.7% of them actually went to healthcare workers. And as you know, healthcare workers are very important in terms of influenza vaccination because they are exposed and they also expose their patients. Now, the good news is as of 23 August, we are now sitting at 81.5% of our utilization in terms of the influenza vaccine. So it looks already a little bit better than last year, but we still need to get to the 100% target in terms of influenza vaccination. Now, the next question is, what are the challenges apart from the ones that I've already mentioned now? So the first challenge is that the household survey that was conducted in 2019, when people were asked why their children were not vaccinated, why they missed certain doses, the most common reason for that was that the vaccines were out of stock. So there's some indication that there could be some health system challenges, but then there were also other reasons, as you can see here on screen, and these things are currently being investigated. Then the next challenge is vaccine hesitancy. So just to revisit the definition of vaccine hesitancy, it is defined as a delay in acceptance or refusal of vaccines despite the fact that these services are being available. And it actually ranges on this sort of arrow from the point of where people can actively demand vaccination onto the other side of the sort of the arrow or the range where people will refuse vaccination. And what we need to remember is that vaccine hesitancy is a very complex phenomenon, and it's influenced by multiple factors, and it's also very specific to a specific vaccine. So it is not the same for all types of vaccines. Then the drivers of vaccine hesitancy. So research has shown us that there are 5 main drivers of vaccine hesitancy. And these are then the areas where we can actually target our interventions. So the first one is confidence. So that means trusting the healthcare system, trusting the vaccines, the people delivering the vaccines. Complacency happens when people don't feel that these vaccine preventable diseases are not serious any longer. They are actually not harmful. They don't see them anymore. Convenience means that is it convenient for people to get the vaccines? Are they available? Are they affordable? Are they able to get to the clinics? Collective responsibility means, am I responsible for protecting the herd? Or is it not necessary for me and my children to get vaccinated? And then the last one is calculation, where people then actually weigh the risks and the benefits of vaccines and the disease up against one another. So when it comes to the decision to vaccinate, we have seen that there are concerns about the safety, and that is always the most important reason for vaccine hesitancy. So a key factor in this context is the perception of risk regarding both the disease and the vaccine itself. So the basic formula for assessing risk always comprises of these 2 factors, probability and severity. So as a general rule then, if a person then considers there's a high level of risk relating to the illness, they will get vaccinated or they will get their child vaccinated. But if then, on the other hand, they perceive that there's a high level of risk related to the vaccine in terms of experiencing side effects, they will not get vaccinated or they will not get their child vaccinated. So we need to figure out, how can we actually overcome this perception of risk? What I want to point out here is the challenge of social media. So as you know, especially with the pandemic, a lot of misinformation has been spreading, especially on social media. So we did this study where we looked at social mentions of these repurposed medicines such as ivermectin, chloroquine, and colchicine. And we've seen, when the conversations increased, the use of these drugs also increased. But what was very interesting and disturbing, actually, is the fact that very few of these mentions, only 10%, actually came from healthcare workers, including pharmacists, doctors, caregivers, and so on. And pharmacists was less than 1%. So the question is, who are actually informing the public out there about things, for example, using these medicines, as we've seen during the COVID-19 pandemic? So this is a challenge, who is actually spreading information on social media. Now, the next question is, what are we aiming for? So the first thing that I want to point out is the Immunization Agenda 2030. Now, there are 3 main goals, as you can see here. The first one is life course vaccination, and that's going to become very important for the pharmacist in future. The next one is to leave no one behind. Everybody should have access to vaccines and should get those vaccines. And then the third one is to strengthen immunization services within primary health care. And this is also where the pharmacist now will play a very important role, especially as we are moving forward with the NHI. Now, I mentioned life course vaccination and that it's going to be very important in future for the pharmacist. You must also be on the lookout that's for a policy statement that will be published by FIP in terms of the role of pharmacy and pharmacists in future in life course vaccination. So this means that there are specific vaccines recommended at each stage of life, from pregnancy right through up to the point of the elderly person. And if you look at the yellow vaccines here on the screen, these are the ones being part of our immunization schedule, our EPI. Hepatitis B birth dose will be introduced next year, but only for certain babies. And then rubella will also be introduced next year. But as you can see, there's still a lot of work to be done in terms of making sure that everybody gets all these vaccines throughout the life course. Now, in terms of targets and strategies for immunization recovery, these are the ones, and I'm not going to go through this list in the interest of time, because I'm going to cover it in the slides that are coming up now. So the next question is now very important. What can we as pharmacists do where we work, as I said, whether it is in a hospital, in a community pharmacy, or in an academic setting? So pharmacists are trusted by people as, the part of the healthcare team. And this study has shown that in South Africa and in the UK, pharmacists are the second most trusted persons when it comes to health issues and, getting advice on health issues. In South Africa, second to doctors, and then in the UK, second to nurses. So if we look at the US, we see more or less the same situation where it's also nurses, doctors, and pharmacists ranking the highest when it comes to trust in terms of honesty and ethics. So we are trusted healthcare professionals. This was published based on an interview done in the US, but it applies to all pharmacists, and it's all about why are pharmacists such trusted healthcare professionals. And the first reason here provided is we are available, and indeed, if we look at the pandemic, who stayed open, who is available, it's the pharmacists. Pharmacies are accessible. Also, pharmacists are very approachable and people become familiar with them. And then thirdly, pharmacists are reliably helping people on a continuous basis. And then he also pointed out something very important, and that is in terms of the communication, frequent communication. And he also said even more frequent listening being very important. And that's why people feel that they can actually go to pharmacists and they trust them. Now, this article very interestingly pointed out the importance of the primary healthcare setting actually in overcoming vaccine hesitancy and building trust and confidence in vaccines. And this is where we as pharmacists can play a role together with doctors and nurses, because we know how to provide access. We are placed in convenient places. We know how to convey trusted messages and to actually, get people to feel more confident about vaccination. Also, a very important role in terms of reducing missed opportunities to integrate the child health or to provide an integrated child health catch-up service, and then also to provide access to adult vaccination. So this means that at each and every encounter, whether a mother brings in a child for another problem, whether she brings in 2 children, up to the age of 12 years, we should use each and every opportunity to check whether the child received all their scheduled vaccines and whether they received any missed doses. And then also to use these opportunities to provide information and access to adults to vaccination. And very important to bundle them with acute and chronic care. So you should use those opportunities. If you don't use them, it means it's a missed opportunity. Then two very important roles for pharmacists is to practice good, effective vaccine management, and then also effective supply chain and cold chain management. And we've also seen that during the pandemic. So empower yourself, to get skilled in these areas. Now, to go back to the bridging the risk perception gap, very important to just keep in mind that we as healthcare professionals, we base our risk perception based on science and our training, while members of the public base their risk perception on their own emotions and information and what they get out there, for example, with social media. So we need to use, very good and specific communication skills in terms of listening, understanding, transparency, trust, respect, and honesty when it comes to communicating with patients so that we can overcome this risk perception gap. And as I mentioned in the previous slide now, we need to look at how do we communicate. Make sure it's two-way communication. Use, very important, use personal narratives, base your facts on evidence, and never be judgmental. Then when we start the communication, the conversation in terms of vaccination, research has shown that you should always use a strong recommendation. When you use a strong recommendation, people are more likely to vaccinate their children. So, for example, in the case of HPV, recommended because it protects against cervical cancer. Also use the presumptive style of communication where you presume that the person is open to vaccination and the parent or the person wants to get vaccinated. If you leave it open to them to make a decision, it also communicates the fact that you, as a healthcare professional, is yourself not being confident in recommending the vaccination. So very important to use a presumptive style of communication. Then we've seen in the pandemic, through all the surveys, that vaccine safety came out as the top reason why people are hesitant to vaccinate. And therefore, it's important to be transparent at all times, to communicate regarding the possible side effects, and to encourage people to immediately report all adverse events. So the MedSafety app is available for healthcare workers, healthcare professionals, as well as the public. And you should make sure that you communicate that to all your patients or vaccinees. Then the public-private partnerships are very important, and people are not aware of it often, that they you can go into a service level agreement with the EPI program in your district, in your province, and you can then provide the EPI vaccines in your pharmacy. So there are certain, conditions that you need to comply with, including being, have a trained vaccinator in your pharmacy, and then to have or sign up the service level agreement. So the training of pharmacists as vaccinators, the Pharmacy Council has developed criteria for a course that's accredited by them, which is provided by universities. So you need to then go through this course, complete the qualification or the certificate, and then you can apply to then be a vaccinator and provide vaccination services in your pharmacy yourself, or you can have a nurse in your pharmacy to provide these services. So the service level agreement then will allow you to provide the EPI vaccines free of charge to patients in the pharmacy. Then lastly, what pharmacists can do is community outreach. So there are so many opportunities, and you can never do that alone. So I want to encourage everybody to think out of the box. You can go into collaborations with organizations, with churches, with schools, with universities, with the association. There are so many opportunities that you can actually use to provide a community outreach and get involved in catch-up campaigns when it comes to vaccination, as you can see here. Use also those opportunities to make it widely known and to educate the community. also to bundle it with other, long-term conditions, chronic conditions, for example, hypertension. And as you can see here, use the opportunity to then educate the community out there. Here you can see we have combined it actually in reaching out to the taxi drivers, and then also to provide them with hand sanitizer during the pandemic. And then also to get involved with social media, and as well as then bundle it, as I said, with other chronic conditions, so that you can also make vaccines available to adults as we are moving towards life course vaccination. So in conclusion, the pharmacist plays a very important role and is a critical role player in vaccination, because they are trusted and accessible to the community out there. They have the opportunities to identify and address missed opportunities and make sure they don't happen. Advocate and build confidence in vaccines so that we can create demand for vaccination. Empower yourself, go through training, get being qualified as a vaccinator, and then, also make use of the opportunity in terms of public-private partnerships. And then lastly, as I've shown you some examples of community outreach and collaboration to catch up on vaccination and make vaccination more available and accessible in the community. So thank you very much for listening. Let's protect our communities against all these deadly vaccine preventable diseases. Thank you very much.
Thank you so much, Maya. You summarized it nicely. I really, really like the last line. I think it's challenging all of us as healthcare educators to go out and educate our communities, involving community engagement and promotion of medicine safety, but most importantly, communication and doing it the right way. I am going to go straight to introduce the next speaker. I am going to request, we are going to have a question and answer session later. Okay. I hope you can hear me. Yes, we're going to have a question and answers later. Those who are joining us via YouTube and Facebook, you can start posting your questions in the comment section. And those who are on Teams, you would have to raise your hand later once we're done with the presentation, and then we will take those questions. Now, straight to our next speaker, I am so glad to introduce Dr. Ruth Lancaster on the topic, the role pharmacists can play in antimicrobial stewardship, especially in primary healthcare settings. A little bit about Dr. Ruth. Ruth is currently working at the South African National Department of Health under the Affordable Medicine Directorate as a pharmaceutical policy specialist. She works within the Essential Drug Program, through which the selection of essential medicine is conducted and monitored. She is currently a member of the Secretariat for the Ministerial Advisory Committee on Antimicrobial Resistance and the Third Line ART Peer Review Committee. As you can see, ladies and gentlemen, we are in the right hand. She studied for her pharmacy degree at Rhodes University and continued with a postgraduate degree in clinical pharmacy at the same institution. After completing these studies, she worked as a clinical pharmacist within the private sector arena, and before moving to the department around the end of 2015. Dr. Ruth, I hand over to you, and thank you.
Thank you for such a wonderful introduction, and welcome to everybody. Thank you for inviting me to talk about this topic. I have load shedding at the moment, so I'm sitting in the dark, so I'm not even going to put my video on for a moment. Let me just share my presentation. Yeah, that's not working. Okay, it can't load that way. Great. Can everyone see the presentation? Yes, great. Let's get cracking then. Okay, so this topic is particularly talking to the primary healthcare or the community setting. Not to say that we don't consider our hospital colleagues or our colleagues working in pharma or anywhere else, but we rarely talk about antimicrobial stewardship in the primary healthcare setting. So this topic was particularly requested, and let's see what we can do here. I was just thinking as Hanley was talking in her presentation previously that we are putting quite a lot on the shoulders of pharmacists. I don't know if you've noticed what a central role you are having in dealing with doctors, nurses, and the patient. It's almost like pharmacists are a bit of a linchpin. Somebody can't see the presentation. But everyone else has indicated they can see. Maybe you should try the YouTube or the Facebook options. Moving on. So what is actually happening in South Africa? Let's have a little bit of a background. So way back when, in 2014, the World Health Assembly decided that they're going to accept a resolution that the World Health Organization made, such as combating antimicrobial resistance, including antibiotic resistance. So this has been happening for quite a while, 10 years ago already. In South Africa, we started working on our antimicrobial strategic framework, and it was released in 2015. We rapidly moved on to develop our implementation plan, which was approved. Please share YouTube link. And our implementation plan was approved also in 2015. Thereafter, we started developing guidelines, and the first one that came out was our antimicrobial stewardship guideline, and this is based on One Health. I'm not sure how familiar people are with the One Health concept, but that is when we consider human health, animal health, and the environment. So the strategic framework was showing us what we wanted to do. The implementation plan was telling us how we plan to do it. And we developed a bunch of guidelines which supported the how-to, and they had monitoring parameters. And this is basically more of a breakdown of the implementation plan. So what further is happening? So antimicrobial stewardship framework version 2 was developed when we decided that animals should actually also be included in our strategy. The first strategy focused mainly on human health because for some reason antimicrobial resistance sits within the Department of Health, and the strategy sits within the Department of Health. So because we're all human health professionals, we tend to focus a lot on human health issues. So in the version 2 of our strategy, we decided to try and incorporate more of the animal health sector, and we had the South African Veterinary Strategy of 2016 that we incorporated here. Moving along, we also developed antimicrobial stewardship guidelines for the hospital level. And thereafter, we've developed some other documents, such as the surveillance report on antimicrobial use and antimicrobial resistance. We developed some infection prevention and control strategies, and then we had a second surveillance report that came out a couple of years ago. Okay, I've kind of talked about those already. So now, what is this strategy all about? So this is the little house that everything on antimicrobial resistance hinges on in South Africa. And if you look at the gray columns there, those are strategic objectives. Those are the areas that we're focusing on at the moment, sitting with diagnostic stewardship, enhancing surveillance, and surveillance is antimicrobial resistance, the bug, and antimicrobial use, the drug. We're looking at antimicrobial stewardship, which I'll talk about a bit more later, and prevention. So Hanley was talking about that with her vaccination presentation. So these objectives are supported by various enablers, such as health system strengthening, research, education, awareness, and communication. So awareness is really where the pharmacist also comes into their own. And looking over all of these objectives is our antimicrobial resistance governance structure, which I'll show you in the next slide. And at the end of the day, this house is built to support improved patient outcomes, because we all have, even though we all work in different sectors, at the end of the day, we are really concerned about our patients and that they get the best healthcare that we can offer them. So here's our national governance structure. It's called the Ministerial Advisory Committee on Antimicrobial Resistance. And our chairperson, Dr. Chetna, is a microbiologist, and our vice chairperson, Dr. Katrina, is a veterinary equine specialist. You can see we have a diverse membership in the committee, from laboratories, private, public sector. We've got the Department of Agriculture and the Department of Forestry, Fisheries and the Environment, various research organizations, societies, all of the healthcare specialists, except for the nurse, for some reason, and even our regulators. Excuse me. So now, rapidly moving on, with all of this that I've said and how we are focusing at a national level, and I'm coming from a public sector, and we've got guidelines for a hospital, how are we AMSing in primary healthcare? And when I say primary healthcare, I mean the primary healthcare clinics in public sector, or the community pharmacies in private sector. Now, how are we going to AMS in primary healthcare? So where do I start? So this is quite a big project. Like, if you think of antimicrobial resistance, where I think I would be totally confounded if I was told to start tomorrow. I wouldn't know where to look. So I would really recommend taking a look at the guidelines and implementation of AMS, the One Health approach in governance. So the important part here of this huge long title is the governance section, because that actually tells you how you can start putting groups of people together. So setting up your structure. So you have to have, you have to identify who you're going to work with. This is something that cannot be worked in isolation. You really need a team to work together with. So you need to identify what current structures do you have around you that you can work off. Do you have a tea time with your next door neighbor laboratory technician? Maybe you can start having meetings in the tea time. Or do you have a regular meeting with your community pharmacist? If you don't have any structures you can back off, then you're going to just have to start one. Start your own AMS committee. And then you need to identify the committee members, and this really relies on who's actually available, and most importantly, who's actually interested in taking this forward. So you can start off with really interested people and move from there. And in the governance document, it'll really describe kind of the roles, and also have suggestions of people that you can invite to be members of this. For example, if I was working in a clinic, maybe what I would want to have is the chairperson. Maybe I want the highest ranking management representative. And the reason being is I want them to recognize us and our team and what we're doing. And I want to have them recognize our hard work, and that we actually need the Friday afternoon to have these meetings, or we need a room in which to convene. So maybe I would invite my senior doctor, or if I had only one doctor, I would ask that person. Or if I had a visiting doctor, I would ask them to join. I would ask our senior pharmacist or our IPC practitioner if we had one. If we didn't have an IPC practitioner, maybe we would ask a senior nurse who knows IPC functions. I really strongly believe that antimicrobial stewardship and IPC must work together. Do you have a laboratory representative? Maybe you're working with Pathcare, or if you're in public sector, is there an NHLS representative in your clinic or in your district? I'd really recommend inviting them over as well. And anybody else that you think about in your area. What happens if you're working in a community setting? Who's going to be the chairperson? So you, the very energetic pharmacist who wants to get this going, you can chair. And you just need to remember that the chairperson doesn't have to know everything. The chairperson can be the person that gets everyone together, gets them to sit and to discuss things in an objective manner and to come up with solutions at the end of the day. You can have doctors or dentists in the community. Maybe you're working in a medical center and you can invite all the doctors in the area. Do you have clinical associates that you can invite? Are there fellow pharmacists, maybe in the pharmacist across the road from you? Do you have a clinic nurse, or maybe there's a private nurse in the rooms opposite you? Are there any local laboratories, lab technicians that you can invite, and anyone else that you can consider? Maybe you have other specialties in your area. So it's really up to you. So these are some suggestions that come from the governance guidelines. And you can also just take a look there as well to see maybe what you would expect everyone's role to be in this team. So now, once again, where to start? You have actually got your committee together, and now everyone's sitting around with a cup of tea and saying, what do we actually do now? So maybe here are some things that we can start to think about. Antimicrobial resistance surveillance. Do you know what your antimicrobial resistance looks like in your community? Is this something that you need to discuss with the doctors and the laboratory? Can you come together and take a look at what's happening in your area? IPC functions. Are there any sort of infection prevention and control functions that you need to do in your area? Maybe you need to decide to have vaccination outreaches. Are there any training and education things that you need to do? Maybe there's also awareness to the community on the use of antimicrobials. Maybe you have noticed that there's this strange uptake of certain antibiotics, and you need to investigate what is happening there. Are you joining in awareness days? For example, there's a hand hygiene day. There's coming up, there's World Antibiotic Awareness Day, Awareness Week, sorry. Maybe you can do little outreaches during those events. And antimicrobial use surveillance. So I'm going to use this antimicrobial use surveillance as an example of an activity that can be done just now. But at the end of the day, one must remember that this is a huge elephant, antimicrobial resistance. It really is big. And the further you go into it, the bigger the issues and the projects and the activities seem. But you must always remember that it is an elephant. And as Desmond Tutu said, how do you eat an elephant? And it is one bite at a time. So even if it looks overwhelming, just remember, choose your activities, have a project plan, and just go one step at a time. So what else can we offer you that can set you on the path to antimicrobial stewardship in your setting? So we have the primary healthcare standard treatment guidelines, and it is available on Knowledge Hub. You can see this is the Knowledge Hub logo here. We have National IPC Prevention Control Strategy Framework for those that want to take a bit of a further look into IPC. There's also the practice manual for IPC. So I'd really recommend taking a squiz at these volumes. The organizers will show the links to where you can access these on the group chat. There's also the prevention and containment of antimicrobial resistance in a hospital level. But remember, just because it's a hospital level doesn't mean that you can't take a look at this manual and decide what you can extract and change and use for your own setting. There's also EM guidance. So you can find the standard treatment guidelines on EM guidance, and you can download this for free on Apple or Google. And all the guidelines here are free. You can also see some guidelines in other hospitals around the country. They've put on everything. It's not only Department of Health guidelines on this app. There's also the OHSC guidelines for norms and standards. This might be a little bit more of interest in more of a bigger facility setting, and there isn't a lot in here about antimicrobial stewardship as yet, but we are actually in talks with these chaps to start including some antimicrobial stewardship standards in there. Okay, so now let's take a look at the guidelines for the prevention and containment of AMR in hospitals. The purpose for this was prevention and containment, obviously, of AMR in facilities. And we wanted to focus on healthcare-associated infections and their spread, and look at stewardship practices at a hospital level. And the aim is that this is a practical how-to guide. So it's literally a step-by-step, how am I going to get these things done? And our intended users are healthcare workers, doctors, nurses, pharmacists, etc., in a hospital setting. So now the question is, why am I showing you this, and how can I use this in my clinical pharmacy setting? So as I mentioned earlier, you just extract what you needed, because what I'm trying to say here is, as yet, we do not have any guidelines on AMS in a community setting or in a primary healthcare setting. But I'd really want to invite anyone who has any thoughts on this, or any practical application, any activities that you're doing now in a community setting that you're doing with AMS that's really working for you. If you want to engage with me, maybe you want to come on board on the team to develop AMS guidelines for the primary healthcare community, just let me know. We're really in need of some interested parties in this area. So now, as I said, we're going to take a look at these guidelines and see how we can extract it and use it for a clinic setting. So in the book, one of the things that a pharmacist can do is do an antimicrobial stewardship audit and feedback. So this is only one of the activities in that hospital guideline. And I just took this one out for pharmacists and said, let's quickly unpack this and see what it is that we can do in a community setting. So now what it suggests in the guideline is we need to have a good communication strategy. So do you actually know the names of your doctors in the area? Do you communicate with them? Are you in good standing with them? Can you engage with them? Obviously, all of these factors are important before you can start working further with them. Maybe you need to identify them and start communicating with them, or start informing them that you have interest or intention of starting this committee. You have this type of work has to be done in consultation with the doctors, because you're going to audit what they're doing and then you're going to give them feedback. So obviously you'd need them on board as well. And I really recommend that you be transparent with them from the get-go. Then what you can do is you can conduct the AMS audit through your script review, because you get the scripts coming through, and maybe you put a couple of questions together and then on like a form, and then you collect the data. And at the end of the day, what you do is you take a look at the data, and importantly, you'd give the feedback to the doctors. And everybody thinks that they're doing a fabulous job, and you cannot tell them otherwise until you actually show them the evidence. And then they'll be like, actually, you're correct. There's actually room for improvement. I can do this better. And that's when the good communication strategy comes through, because then you can tell them about uncomfortable news that actually your practices could do with a lot of improvement. So some of the aspects that you can review on your script review, for example, would be indication. Is there actually an indication on the script? Do we know what we're treating here? Because how can you say that this antibiotic has been used rationally if you don't know what it's actually used for? I think a lot of pharmacists, we have this thing where we kind of assume and guess a lot of the indications coming through the pharmacy based on what the script looks like. Is it empiric treatment, definitive treatment, or is it a prophylaxis? We want to prevent an infection here. Maybe it's a malarial prevention, I don't know. Is the dose duration route all correct for the patient's weight? I know sometimes in a clinic setting, it might be a bit difficult to judge on a patient's weight, but if you have a child walking through, maybe you want to quickly pop them onto a scale. Have there any cultures been sent to a lab? Is this a question you need to ask? Is this something you need to discuss in your AMS team? And then the general things of allergies and drug-drug interactions, very important. And these are really those quality processes that the pharmacist can bring to this environment. And lastly, I would like to ask you, would you like to pledge your support for antimicrobial stewardship? So these are one of the things that we've developed for the South African audience. And you can pledge to become an antibiotic guardian, and you can actually choose which action you want to take to protect your antibiotics. So you click on this page and you come here and you can say, who are you? I am a vet, I am a pharmacist, I'm a healthcare worker, or I am a regular citizen. And then you click on there, and then as you scroll down the page, it'll say, what do you want to pledge? So it'll say, I will pledge to wash my hands before dealing with food, or whatever your pledge is. And at least you can have that one thing that you can remember to do. Okay, for pharmacy month, I am going to pledge this thing, and every day I'll remind myself I am going to do this thing correctly. And that's pretty much what the pledge is. And I hope that everybody is keen to join the pledge. And that is pretty much the end of my presentation. Thank you, everybody.
Thank you so much.
Ms. Mokoena, you're on mute.
Sorry about that. My screen just disappeared, but I am glad and I am back. Maybe also just to apologize for those online. I've noticed that a couple of the members really struggle to see their presentation, but it seems so far we are good. If you are still struggling, we've just checked. I think the YouTube and the Facebook is going quite very, very well. With those few words, thank you so much, Dr. Ruth. The very last slide. We need to pledge as pharmacists to do things right. And I think that is the beginning of us really changing the way we do things to the next level. Without wasting too much time, I am going to introduce Mr. Erwin Tammy, our last speaker for the day, of the evening. And he is going to cover the topic, identifying adverse drug events, how to report them, and what happens with the reports. Little bit background about, don't want to say Ivan is Erwin. Born and raised in Zimbabwe, graduated from Rhodes University in 2008, done internship at the School Hospital, community service at Vryburg District Hospital, practiced clinical pharmacy and advanced pharmaceutical care from 2010 to 2016, with clinical rotation in various public sector hospitals in PE, and the list goes on. Currently working at the Medicine Information Center since 2016 as an information pharmacist and pharmacovigilance officer, responsible for training and assessment of adverse drug reaction as part of Western Cape Pharmacovigilance Program. Welcome, Mr. Top.
Thank you very much for the introduction, and thank you everybody for attending, and I hope this gives some motivation to us reporting adverse drug events and being part of the pharmacovigilance activities. I'm just going to load my presentation. Thanks. Please let me know if it's loaded correctly. I'm getting a thumbs up from Nokutula. Does that mean it's all clear? Can everybody hear me as well?
Yes, you can go ahead.
Yes.
Thanks so much. So the final topic today, I'm going to try and not keep you all too long, but I'll try and just touch on the main points with regards to adverse drug events and adverse drug reactions. Please excuse me, I don't have my camera on as well with load shedding, but just to give you an overview, that is myself and the Medicines Information team. We are situated in the clinical pharmacology department of the University of Cape Town, and our main role is to help with any medicine-related queries from healthcare professionals. So we have the Medicines Information Center and the National HIV and TB Healthcare Worker Hotline. So any medicine-related queries, please feel free to contact us throughout the course of Monday to Friday from 8:30 to 4:30. So to start off with, I just thought we'd just cover a few definitions and terminology. So overall, pharmacovigilance is the science and activities, and this is related to the detection, assessment, as well as the understanding and prevention of any long-term and short-term adverse effects or adverse drug reactions of medicines, as well as any other medicine-related problems. Now, just a few terms that often we've come across, and there's often a confusion, and hopefully I can just clarify the different terminologies and where they place into pharmacovigilance. Overall, your adverse drug event refers to any untoward medical occurrence in a patient or clinical trial subject that's administered a medicine and may present during treatment with that medicine, but which we're unsure at that point whether or not it is due to that medicine, so we don't have a causal relationship with the treatment and that event. But otherwise, any unfavorable and unintended sign, symptom, or disease temporarily associated with the use of the medicine, whether considered related to the medicine or not, is considered an adverse drug event. Now, contrary to an adverse drug event, an adverse drug reaction or adverse effect, as often is also used, is referring to any response to a drug or medicine which is noxious, so adverse, and is unintended, and can occur at doses normally used in men for prophylaxis, diagnosis, or treatment of disease, as well as for any modification or physiological function, including the lack of efficacy, and any effects that can result from overdose, misuse, or abuse of any drug. So that term covers quite a lot, and the focus here is on the effect and contributed by that drug, and that effect is harmful and unintended to the patient. Now, a further term, medication error, which we often refer to as a preventable ADE or ADR, and this refers to any preventable event resulting from failure in the treatment process, involving prescribing, dispensing, as well as medicine preparation, the administration, and monitoring errors, which has the potential to cause or lead to inappropriate medication use and harm in the patient. So just to try and illustrate these terminologies, so in adverse drug event, using an example of a patient going out in the night and has a motor vehicle accident. At that time, we're unsure of the medication the patient's on and what time they took the medication, so we don't have a causal relationship established. However, we are aware that the patient has been on these medicines, so at that point, we're suspecting an adverse drug reaction, and that would be reported as an adverse drug event. Now, on further causality assessment, we can then establish a possible causal relationship between the exposure of the drug. So in this case, it's identified that amitriptyline was administered at 9 p.m. and then shortly afterwards, the patient decided to go out driving, And during that time, the adverse drug reaction that attributed to the accident and death was that onset of drowsiness and the patient falling asleep at 10 p.m. So at this point, we have a causal relationship between the exposure of the medicine and the occurrence of the event at 10:30 p.m. Now, if we're looking in terms of medication errors, in the example, in this case, the patient instead takes 50 milligrams of amitriptyline instead of 25 milligrams that was prescribed. That would be considered a preventable adverse drug reaction and preventable adverse drug event. So when we're looking at these terminologies, and just to put them into perspective in terms of their relationship, our main focus is on understanding the harm related to these events. So just to illustrate on the slide, I'm just going to try and put a pointer. So our main concern is with harm. And historically, medication errors and adverse drug events do link in some point with regards to harm. So a medication error can occur or it can exist, but doesn't always result in harm. So the harmful occurrence is this intersection with adverse drug events and adverse drug reactions. So medication errors often do occur, and they often go unnoticed, but often they don't. The majority do not reach patients. But when they do, they can present with harm, and as a result, your adverse drug reactions or adverse drug events that are preventable are very important, and those are the aspects of these events that we're most interested in identifying. So in terms of adverse drug reactions, again, there are a component of adverse drug events, but not all adverse drug events result in adverse drug reactions. And again, as with most medicines, as much as we would like to avoid adverse effects or adverse drug reactions, there are those non-preventable events, in which case we've controlled for everything. We ensured rational medicine use of that drug. There are cases that unfortunately we will always have adverse events occurring, and in that case, non-preventable adverse drug events and adverse drug reactions. And why is this important? Well, overall, we didn't have much data in the past, and still we are improving our reporting and trying to investigate further with regards to the significance of adverse drug reactions and their contribution to harm and overall comorbidity and morbidity, mortality effects. And this is one of those studies that we do have good information, and to highlight the importance of why we need to be vigilant with regards to the incidence and significance, clinical significance of these events. So Mouton and colleagues retrospectively looked at the occurrence of hospital admissions and the incidence of adverse drug reactions and those that were preventable across hospital admissions to 4 hospitals in South Africa. So this was in a period in 2013 with a sequential 30-day follow-up at 4 hospitals prospectively. And what they found is for every admission, 1 in 12 admissions were due to an adverse drug reaction. And of those adverse drug reactions, 45% were preventable. Now, that's quite a very high number if we think of patients are being admitted 50% of the time when they experience an adverse drug reaction, and it could have been prevented. Similarly with mortality, mortality numbers are low, but with any death, one death is very significant. So as much as ADRs contribute to the death of 2.9% of medical admissions, with an overall mortality of 18 deaths per 100 admissions, and 16% of these deaths were ADR related. And similar to the hospital admissions, 43% of the adverse drug reactions, deaths related to adverse drug reactions were preventable. So we have quite a significantly high incidence or prevalence of adverse drug reactions, and of course the preventable adverse drug reactions which otherwise we could have resolved or prevented early on before these serious outcomes. So just looking overview, there's various ways to classify ADRs, and I've just put this in as well to illustrate, as I often get asked, where do side effects fit in? Because we often get that term used in. So in this case, side effects are a subcategory of adverse drug reactions. So we will refer to those as type A adverse drug reactions. Initially, we classified adverse drug reactions as type A, augmented, and type B, bizarre, but that classification has expanded to include type C, D, E, and F. I'm not going to go into much details, but just to fit in, side effects are what we know of the medication based on their pharmacological properties. So your type A, C, D, E, and F type of reactions are going to be some way predictable from their pharmacological properties, and often these are of low mortality, and because they're predictable, we're able to at least identify them and try to monitor and control them or for their harm. But we also have those adverse drug reactions that are not related to their pharmacological properties, and that's your type B, or which includes your immunological reactions, so any hypersensitivity or allergic reactions, as well as any idiosyncratic reactions where we don't understand fully the cause and etiology for those reactions, and that fits into type B. And we often come across these in the front of patient files where we have their allergies listed, and often because they are often unpredictable, when they do occur, they often have this high mortality or risk factors involved and serious outcomes. So as much as we use that terminology, we know of adverse drug reactions, but I thought this phrase by Donald Rumsfeld fits in quite well with what we know of adverse drug reactions. And this was at a US defense briefing on weapons of mass destruction, but I think it fits the picture of adverse drug events as well. And what he said, there's known knowns, there are things we know. We also know there are known unknowns. That is to say, we know that there are some things we do not know, but there are also the unknown unknowns, which are the ones we don't know. And just to put this into perspective, when we're looking at studies, so if you go into a package insert, most of that information is based from studies during clinical development, but there are quite a few limitations to trials and studies, as well as in preclinical animal experiments during phase 1 to 3 clinical trials. In this case, there's limited or lack of data to predict human harm and safety of all reactions. Trials are often very expensive and demanding on resources, so there's limits to the number of participants, and with short durations for follow-ups. Trials also have conditions and indications which are often limited and differ from those in clinical practice. So they might only be looking at a specific disease state, but we know in real life situations, patients have multiple comorbidities. So the way that the response to their medicine may be totally different than when we're in the real world environment. Similarly, we're going to have limited information of that unknown safety data from long-term and rare reactions because of that small number of participants. And very similarly, when it comes to excluded populations, particularly in the elderly and children, as well as in pregnancy and breastfeeding, we have very limited data to support the safety and efficacy often in those in those populations. So just putting that into perspective of the known knowns, the unknown unknowns, during your phase 1 to 3 trial and just prior to registration, we're only going to be at least able to pick up your very common to uncommon adverse effects. So with an incidence of 1 to 10 in 1,000 or more than 1 in 100. And those are going to identify our ADRs that are most likely to occur, your short-term effects, your known knowns. The ones that we are interested with post-marketing surveillance and part of spontaneous reporting is those rare and very rare adverse drug reactions where we have limited and lacking information on long-term and rare adverse effects. Now, just put into play the rule of 3 in statistics. What that generally means is for us to be 95% confident that we observe one occurrence of an event, and that event is not due to chance or due to similar incidents in your patients not exposed to that medicine, we require at least 3 times the size of the event's frequency for that in that trial for those patients to be exposed. So for us to pick up a very rare adverse drug event or adverse drug reaction of less than 1 in 10,000, we're going to need a population size of at least 30,000, which we generally will not get in any clinical trials. Hence the importance of spontaneous reporting and post-marketing surveillance once that medicine is registered out in the market and is being used by a larger population. Okay, so going from that, there are various methods for detecting adverse drug events. The main method we will be focusing on is spontaneous reporting, but there are other methods, and those that are commonly used are chart review, computerized surveillance, as well as direct observation. Each of them have their pros and cons. Voluntary is the most common method used, but has the least is the least reliable when it comes to overall incidents or reporting of adverse drug events compared to medical record or chart review, which has been reviewed to detect more adverse drug events than spontaneous reporting, as well as compared to direct observation and your computerized surveillance. There is the use of trigger tools, which are lists of clinical clues that would help to identify whether or not an adverse drug event has occurred. And examples of this would be, listing high-risk drugs such as your antidote medications. So if it's prescribed, these trigger tools would be able to list or identify certain medications that are high risk. So in the case of naloxone for opioid-related adverse drug events, that would be a trigger to investigate further. There could be abnormal laboratory tests in terms of renal function or transaminase elevation of liver enzymes that may indicate medication-related toxicity. We have the use of other symptomatic treatments. So the case of using Allergex could be a signal that there's an immune response or an allergic reaction, and those are used in conjunction with medical record or chart review to identify these adverse drug events. Computerized surveillance has, as with technology, has grown with interest, and this has helped to capture reporting and support voluntary reporting, and it's useful especially to monitor large patient populations continuously. However, accessibility at this point is very limited, and these surveillance systems are quite expensive to purchase as well as maintain. Direct observation is a most effective method to detecting adverse medication errors, especially administration errors, but again is time consuming, is labor intensive, and very expensive. Reporting by patients and family members has become an interest as well, and to complement other approaches, and has shown some value, especially with regards to spontaneous reporting, but there's still research needed to its performance in operational settings before that becomes more popular. But as mentioned, we would be focusing on spontaneous reporting. And this is the main method of reporting by the majority of the countries that are registered with the WHO International Drug Monitoring Program. It's a passive surveillance method, so that means it's voluntary, it's spontaneous, it's easy and least labor-intensive method amongst the methods listed previously. We can cover all populations and include all medicines, and we can monitor throughout the life cycle of a medicine. And the great thing is we can always detect previously unknown or rare reactions, as well as identify any signals and trends associated with those adverse drug events. The trouble is that it is very limited with regards to reporting, and that's mostly based on underreporting or incomplete reports based on the quality and quantity of data when reporting those spontaneous or those adverse events. There is no denominator, so I often get asked this question on what's the incidence of adverse drug reactions. Unfortunately, without a comparator group, we cannot determine incidence or risk rates. That would require more robust and further active surveillance methods to determine that incidence and prevalence of adverse drug reactions. But again, the main focus is to identify signals and trends associated with those previously unknown or underreported adverse effects. So as mentioned, bias and variance in voluntary reporting is a big factor. So again, what the reporter considers significant in terms of seriousness or severity of reactions, how long the medicine has been on the market, as well as any advertising and promotional claims, or the public's interest in specific adverse drug reactions or specific drugs association. And we've seen a lot of this with the vaccine COVID pandemic and vaccine hesitancy, that reporting has become very important, but there is also much hesitation with regards to reporting and the use of medicines overall in terms of their safety. So I mentioned signals as the main focus with regards to spontaneous reporting. And what we mean by signals is reported information on a possible causal relationship between an adverse event and drug that was previously unknown or incompletely documented. So I think this fits best when I'm asked what should we report. So whether it's an adverse drug event or an adverse drug reaction deemed at that point, remember our main focus here is on previously unknown or incompletely documented safety concerns. And for us to generate a signal, we need more than one report at least, and depending on the quality of the information provided in the report, as well as the seriousness of the event reported. So just to illustrate that, we'd have multiple adverse drug events being submitted, and based on causality and preventability assessment, we would then merit the probability of them being confirmed adverse drug reactions at a possible, probable, definite, or unlikely level. We'd also assess whether preventable or unpreventable. And based on that information, if there's many adverse events being reported, that would create a greater signal for concern that would then prompt further research or studies with regards to that safety incident. So why should we be reporting adverse drug events? Well, all healthcare workers should be reporting, and the Regulation 40 in the Medicines and Related Substance Acts does point out to this fact that all healthcare professionals and healthcare providers should report any safety, quality, or effectiveness concerns to SAHPRA as the authority. Just to highlight, it is a multidisciplinary role, so each profession would play a different role or function depending on also their role in the continuity of care. So your nurses are often going to be your initial contact for complaints, and any observation of the suspected reaction, and as well as referral for evaluation and management of the suspected adverse drug reaction. I'm going to focus more on the pharmacists, but again, your medical officers and other allied healthcare professionals will play a much greater role in the diagnosis of the adverse drug reaction, as well as the overall management of that adverse drug reaction. But as pharmacy personnel, our main focus would be on rational medicine use, as well as our role, which has been highlighted in the National Drug Policy, as well as in the competency standards for pharmacists and pharmacy personnel. And this is our daily bread and butter as pharmacy personnel when we're evaluating prescriptions. So I would say most of us are, well, pharmacists in general are doing their job on a daily basis with regards to rational medicine use, ensuring the right patient, the right drug, the right dose, the right route, and the right time. So I often get asked how to detect suspected adverse drug events, and it is quite tricky, but as mentioned before, as a pharmacist, we're going through those through that evaluation that will often pick up any preventable adverse drug reactions, as well as any drug therapy problems. So just a few points to highlight how I would often go about detecting a suspected adverse drug reaction, and that would usually start with the initial complaint or concerns by their patient. So it's very important to listen to your client's complaints. As much as they would be subjective, you also want to check for any signs as objective evidence to suggest an adverse drug reaction. So is there any new or unusual signs or symptoms that the patient presents with? Any abnormal laboratory test finding? Any abnormalities detected on any imaging or diagnostics? Or any abnormal clinical measurements? Those usually would give you some sign of their patient's complaint related to the specific organ system or symptoms related to their complaint. You also want to ask the client questions related to their treatment and how they feel. They might not always complain, so it's always important to also ask them and also assess their adherence. Adherence is a major factor and often a good indication of intolerance due to adverse drug reactions. So if your patient is non-adherent, it's also very important to ensure that we're checking up, is it due to any adverse drug reactions, whether they're preventable or unpreventable. And from then, you want to take a complete medication history, and that's including all medicines and not only the suspected medicines. Adverse events overall are not always specific for a drug. There are some that are phenomenally associated with certain drugs, like baby Gray syndrome with the chloramphenicol, or your non-urticarial angioedema that occurs with ACE inhibitors, but it's very limited to certain drugs that we can then predict those adverse drug effects or symptoms based on that history. So it's always important to check with other medicines as well what's occurring there. And by doing so, we then want to verify the suspected medicine and other medicines were administered or taken prior to the onset of the adverse drug reaction. We then also want to verify the onset of the suspected adverse drug reaction was after the medicine was administered or taken. And that is generally your most important two factors when you're looking at an adverse drug reaction, suspecting an adverse drug reaction, is that onset the onset of that reaction relative to the exposure of the drugs that are suspected to cause the effect. That is you at least establishing a possible causal relationship. You then want to also consider whether the event is pharmacologically plausible. But again, as mentioned before, there are going to be those events that are idiosyncratic or not related to their pharmacological properties. So to be aware of those cases. Mentioned earlier, we want to then again review while we're reviewing that medication to determine if there's any actual or potential medicine-related problems. So going through the looking at any contraindications by age, gender, weight, or comorbidities, as well as pregnancy or breastfeeding status. Checking the dosing is appropriate, again, for the indication specific for its use, as well as any age, factors, weight, or renal or hepatic impairment. We also want to look at drug interactions, be they with food, disease, or other medicines, and particularly important when there's polypharmacy involved. By polypharmacy, usually we're meaning more than at least four or more medicines. So often we find in the high significance of drug interactions with more medicines being used concomitantly. From there, we want to check if there have been any recent therapy adjustments. So was there a dose change? Was there addition of therapy or discontinuation of therapy, to also determine or predict if there was any previous adverse drug reactions that could have occurred. And based on that, then we would then go on to managing. I'm not going to go into the management, as often that is going to be subject to the type of adverse effects that are presented, as well as the seriousness and severity. But pharmacists would then play a big role as well in following up on these outcomes once an intervention is put into place to resolve or prevent harm. So it's always important to follow up on that adverse drug reaction. We also want to consider alternative factors causing or contributing to the reaction, especially if it doesn't resolve after a period following any interventions. So to also look at, could it be comorbidities? Are there other medicines involved, particularly over the counter, or any complementary, alternative, or traditional medicines? And then whilst we're at that, checking any relevant up-to-date literature to determine, has this reaction been reported? Is it known? Is there details on how to manage it? And we usually would find this in a summary of product characteristics, or your as was also known as a professional information or patient information leaflet. Your guidelines would often also give you details on your very significant or frequent adverse drug reactions, as well as any medical databases and journals. I've just noted there, remember that as there's limitation to trials, we often are not going to see all those adverse drug reactions listed. So if it's not documented, it does not necessarily mean that drug can't be contributing or causing an adverse drug event or adverse drug reaction. Okay, next, looking at what should we be reporting. So overall, we want to report all adverse events with all registered and unregistered medicines, and that includes any medical devices, any in vitro diagnostics, as well as all vaccines, biologicals that are becoming more increasingly popular, and we're getting more use of these agents. And of course, complementary, alternative, traditional, as well as herbal and natural medicines. So overall, any product that's been used or considered to be used for treatment or prevention of illness or disease or disorder should be reported. When it comes to the type of events to report, there's different terminology in terms of the seriousness or severity of an adverse drug reaction, severity measuring the extent of the impairment or harm, and there are different categories to determine the severity. But we most especially focus on the seriousness, so the outcomes or potential outcomes from that adverse event. So I've highlighted the most serious or severe events that we would especially want to report. Those that result in hospitalization, whether it be initial or prolonged, any disability or impairment, be it temporary or permanent, any congenital anomalies or birth defects, as well as any life-threatening reactions, so at the time may present as fatal, and if not managed appropriately could result in death, as well as all those reactions that have been associated with death. I have also included any intervention to resolve or prevent any harm, as that often is a trigger to assess, even if we're unsure at that time how severe or how serious it is. If we're intervening to prevent, means it's significant enough for us to report. So not only looking at the harm or outcomes of harm and seriousness, severity of reactions, we also want to report in those significant events. So in children, elderly, as well as during pregnancy or breastfeeding, we have very limited data in those populations. Similarly, with any fetal or infant exposures during pregnancy or breastfeeding, including those inadvertent exposures, and we do have pregnancy registers available for monitoring and following up on those adverse drug reactions during inadvertent exposure in pregnancy and breastfeeding. We also want to report any adverse effects, whether they're known or unknown, to newly marketed products. So any product that's been on the market for less than 5 years, as often we don't have much data on those products yet. If there's an adverse event or adverse drug reaction that's not clearly stated in the package insert, those should also be reported, or any adverse drug events that are occurring more frequently than previously reported, as well as any resulting from interactions or any therapeutic failures. So that's quite a lot to remember, and SAHPRA has guidelines that have tried to summarize a stepwise approach to determine should you report all adverse events. So I've just highlighted with regards to product quality concerns, as well as often there may be adverse drug reactions such as therapeutic failure that could result from product quality issues. There could be contaminants or toxic breakdown products. So if it's suspected, and we do suspect an adverse drug reaction as a result of product quality issues, those should be reported. Similarly, as I've summarized, we want to report any serious or significant reactions. If they're not well described in the package insert or summary of product characterization, we would also want to report those. If it's a new product, or if it's occurring in any patient that's a child, elderly, pregnant, or breastfeeding. It's a lot to remember, but if you're unsure or in doubt, it's always good to report. There's never any harm, and there's no blame put to reporting adverse drug reactions. The more information we can get, often it would identify a signal, and we can always follow up on that adverse drug reaction if further information is required. So once you're reporting those adverse drug reactions, SAHPRA is the main regulatory authority and responsible for national pharmacovigilance overall. So I've just highlighted the methods of which you can report adverse drug events, and that would be adverse events following immunization, adverse drug reactions, or product quality concerns. There are a few differences. So with regards to adverse drug reactions and product quality concerns, you can use the forms from SAHPRA, which can then be emailed to their email address. There is also electronic e-reporting portal that is available for those that would like to report online, and the mobile app, which is becoming more popular and promoted as the easiest, most accessible way for reporting, not only for healthcare workers, but also for patients that are also encouraged to report. Unfortunately, at the moment, for APHIS, we rely mostly on the forms, and those should be submitted through the National Department of Health APHI email address, and to include your district EPI surveillance officer. It's very important, so they can follow up on the investigation, designate a unique ID number for that case, and for causality assessment. The assessment in this case is more thorough, and as we've seen with COVID-19, there's been a lot of focus and highlight on assessing those adverse drug reactions overall. They can be reported also via the mobile app, but unfortunately at this point of time, the internet, the e-reporting portal is not available for reporting adverse drug events following immunization. I'm not too sure if this is clear, but this just an example of the reporting form. Just to note as well, there is a consent clause. So as much as you do provide your personal details and the patient's details, that is kept private and confidential. The only time we would make use of that is to contact the reporter if we need to provide feedback on that adverse drug reaction, or if we require follow-up on the management, or give input or require further information for causality and preventability assessment. So that information is confidential, and there's never blame, or we will never follow up to blame that the adverse event was as a result or contributed by the reporter or the patient. So these reports are solely for identifying reactions. We would address preventable adverse drug events, or if there's management required to prevent further harm, if there was a suspicion of an adverse event and the wrong drug was implicated. For those reasons, we would provide feedback. Similarly, with your AFEs, there are different forms. So you've got your case reporting form, highlighted in green, your case investigation form, which you would fill in for your more severe and serious adverse drug reactions. So if it's a mild to moderate adverse reaction, they are listed in the forms. You would just submit the case reporting form. Please remember again to include the consent form when submitting AFEs as well, in terms of the POPI Act compliance. So once those reports are assessed, SAHPRA's response, there's various responses that SAHPRA can make with regards to any safety concerns that are highlighted from those adverse drug reactions and signals that are detected. There can be changes to product labeling, which can be the addition of warnings, any precautions or contraindications, or any adverse effects that need to be updated in the professional information, as well as the patient information leaflet. We would also distribute any Dear Healthcare Professional letters or publish any medicine safety alerts in medical journals to inform healthcare professionals of any new or updated safety concerns related to medicines, as well as issue press release to inform consumers. So that's become increasingly important. We want to get that information not only to healthcare professionals, but as well to the patients, the consumers, that's the end user. There could be limits or restrictions on the access to these products by either upscheduling or limiting prescribing indications or the population authorized for use of that medication. There could be recalls, suspension or cancellation of the registration of the product, depending on the severity of the reaction and its significance, as well as any further post-marketing studies if needed to investigate the safety concern as more information is needed. So just to summarize overall in this pharmacovigilance cycle, as the healthcare reporter, you're going to be involved in detecting as well as managing any suspected adverse drug reactions. Those reports can be sent to the pharmaceutical company directly, who would then also forward it to SAHPRA, or you can report directly to SAHPRA. From there, the Pharmacovigilance Center would be responsible for assessing and researching those adverse events, so determining causality and preventability, signal detection, identifying any trends and risk factors, as well as training and education overall on adverse drug reactions and pharmacovigilance. So at a national level, SAHPRA is responsible, and from that database, once those are submitted, Vigibase is the database that those adverse events would then be reported, and that is shared with the Upsilon Monitoring Center. So it's a global database, and they would then include all that data from the registered countries included in the the Uppsala Monitoring Center, WHO drug monitoring program. So it is quite a large database. So just remember, even if it's one report, it may contribute to a signal. There may be other reports from other countries that were not known at the time. So reporting one report is very significant and has an impact overall when we're looking at that database and picking up signals, not only nationally, but internationally. And then just from there, as mentioned, once those signals and trends are put into place, regulatory and policymakers would then estimate and understand those adverse drug reactions by either doing further studies to determine the seriousness and severity of those reactions, find out if there's those trends and risk factors are associated as they were suspected from the initial assessment, and overall determine any incidence and prevalence. But at the same time, that information is going to be useful to help review and update rescheduling restrictions, as mentioned in the previous slide. And once that data is then combined together and thoroughly assessed by a team of experts, clinical pharmacologists, that information can then be distributed and disseminated into guidelines, any relevant policies and protocols or restrictions, as well as any medicine alert and recalls to inform and prevent not only the patient, but also the healthcare provider. And that cycle is throughout the life cycle of that medication. So the process of detection, assessment, understanding, and prevention continues throughout the life cycle of that medicine. So I did show the forms, but just to briefly show for those that are looking to find those forms. So on SAHPRA's website, you want to click on operational units, and from there navigate down to safety information, and from there your health products vigilance would then scroll down and navigate to product quality or reporting safety and quality concerns, and you will have those forms for APHIS and adverse drug reactions available there. I have put together just a few QR codes, which I can maybe leave on for a bit for those that are wanting those forms. So those are the forms, as well as those that are wanting to register for or make use of e-reporting or the MedSafety app. And then I've also included the link to the guidelines for those that would want to get more information on pharmacovigilance and reporting adverse drug reactions. That brings me to the end of my presentation. Thank you very much, everybody.
Thank you so much, Ewan. As you can see, Ewan is very, very passionate about this subject. And I think it is evident that this is long overdue. We probably need to make more time to discuss this because it's very, very, this is what defines us as pharmacists. I am going to be assisted by the team. I think we've come to the question and answer session, and I see hands already online. And maybe let me take a few from the team. By the way, with me, Mojo Mokoena, I'm going to be assisted by the National Pharmacy Work Group, which is constituted by the members from the National Department of Health, ICPA, PSSA. Also, we have a Pharmacy Council team and also a presenter who are going to assist us with the questions and answers. Also safe to say these presentations are going to be made available to the members. We will communicate by the end where you can access this presentation. Now, I'm going to need some assistance over here. Natalie.
Yes, Mokoena, our very first question came from Mr. Mafarafara. He said, thank you for a great presentation, Prof. Meyer. With pharmacists being very accessible in South Africa, how would adding vaccines administration in the public sector pharmacies look like, considering a value-add package in that area?
Thank you. Thank you for the question, Farah. Yes, so I think at this stage, I would say for the public sector hospital pharmacists, I think their role would be more in terms of effective vaccine management, supply chain management, cold chain management. And then in addition to that, to work together with the clinics and, the district teams in terms of, outreach campaigns, catch-up campaigns, and so on. That's where they can play a role, because in most pharmacies, they actually don't administer the vaccines in the hospital itself. It is being administered at clinic level. So that's where I see them playing a very important role, and it is actually a very important role. And there's going to be effective vaccine management training coming available. It will be around the end of November on the Knowledge Hub. There will be 10 modules. So everybody must be on the lookout for that training as well. So I hope I've answered your question. But yes, I mean, in other countries, especially in the private sector hospitals, pharmacists play a more sort of a prominent role in the administration of vaccines as well. So I think it all depends on the situation. Thank you.
Thank you so much for that. Can we take at least 3 questions if we have online, and then the speakers will then just respond to those 3?
All right, Ms. Mokoena, the first question comes from Mornay. He asks, which Department of Health system can be used to check a patient's vaccination status? Then we have 2 questions from Farouk. The first, we are currently sitting with the challenge of non-registered persons supplying scheduled medicines leading to adverse drug reactions. Scheduled medicines are available in shops, in pharmacies run by unregistered persons, and even available on streets. Is it not time that our regulatory bodies play a bigger role in combating such practices? And the last one, is there any progress in reviving the Codeine Care initiative as the substance is badly abused?
Thank you so much. I'm not too sure who's going to take those.
I can answer the question about the way to check a person's vaccination status. So at this stage, only the COVID-19 vaccines are being recorded electronically, and that would then be in the EVDS system. So if you have access to the EVDS, that's then where you will do where you'll be able to check for a vaccinee himself or herself. They can then do it themselves, but I mean, you do need obviously your ID number and so on. For children, unfortunately, we don't have any electronic records at this point in time in South Africa. So all those vaccinations must be recorded in the Road to Health booklet. And yeah, it's a paper-based record. But yeah, I don't know. But with regards to the EVDS, I hope and I foresee in the future that they will expand that so that we could have electronic records available for everybody, especially moving into life course vaccination, where, adult vaccination is going to become more important, and, developing schedules for adults and so on and so on. Thank you.
Thank you so much. On the 2 questions, I would respond to those. One, the question regarding Codeine Care, there is work that is currently being done by the Pharmacy Association, Pharmacy Council, and SAPRA on this matter, and we will be communicating in terms of the strategies and how we think we can stand together to try and manage this issue, because we are aware that it's really, really getting out of hand. The issue of registered medicine in shops under unregistered persons, Pharmacy Council is also working with SAHPRA to also manage those. And issue being the what is the right term? That term is gone. But where in Pharmacy Council can only act where we talk to registered person, and even in this unregistered facilities, if there's a pharmacist there as Pharmacy Council, if reported, we will act on those. Once it is unregistered person and like in a shop, then the jurisdiction, that's the term I was looking for, it falls back at SAHPRA. But safe to say, in 2023, we have worked very closely to begin to come up with ways to deal with this problem, because we have noticed that it is really, really growing at a fast rate. We are hopeful that as the years goes by, will be much more visible, and especially the challenges where we have unregistered people handling medicine in these shops. Thank you. I am told there's 2 more questions I'm going to ask. Oh, Haneli, I'm not too sure if you are adding or you are responding to some of the questions. Thank you.
I just want to, Moju, I just want to make a comment with regards to the reporting of the adverse events following immunization. I would like to encourage everybody to report on the MedSafety app as far as possible. If you sit in Honolulu and there's no way that you can access the app or whatever the case might be, then use the paper-based reporting form. The reason for this is that all our data gets accumulated with the data from other African countries. And the data then, the combined data is then used to identify any possible signals and to verify the safety of the vaccines for the African continent. So I mean, as I said, you can report on the paper-based form, but it means someone will have to sit there at SAHPRA or at the Department of Health and physically enter the data into the system if we want to add the data to the big pool. When it comes to the case investigation, then yes, there's no electronic forms available, or electronic means available. So then the form must be completed, and I think it's about 6 pages, if I can remember correctly. So I just wanted to emphasize, please report on the MedSafety app. Thank you.
Thank you so much, Prof. Meyer. Before I take the next 3 set of questions, I'm going to ask Andre to respond. There was a hand which is up. Can I request that hand remain up? It came and it left very, very fast. Andre?
Thank you, Mojo. I just want to add on the situation where you're finding scheduled medicines being sold in unregistered shops or by unregistered persons. There is a way of reporting it to SAHPRA, and SAHPRA does act on it. If you struggle with that reporting process, you're welcome to contact one of the associations to assist you. But SAHPRA is really good at reacting on those, and they do take action. And so please do report them, but also please provide proof. The more proof you provide, the more information you provide, the easier it would be for SAHPRA to take action and to find the correct place and find the correct offenders. And then just also on the coding situation, to say, yes, there's a lot of things happening behind the scenes on Coding Care, and there's a lot of stakeholders being involved in this. So watch this space. We can't reveal the information yet, but there is progress happening. Thank you.
Thank you so much. The next 3 set of questions, I'm going to open for that.
Thank you, Ms. Mokoena. We have a question from YouTube. We are keen to develop a guideline for community pharmacists, guidelines for the prevention and containment of AMR. How can the DOH be contacted? Then Ruben asks, are we supposed to report when the side effects are common? Example, the patient is taking 2 drugs and gets side effects on both. And then Pasky asked, Ewan mentioned SAHPRA and Pharmacovigilance Centre role in ADR's reporting and processing, but did not say how one can work with his team.
Thank you so much for those 3 questions. Ewan, are you going to assist us with those?
Sorry, so I didn't hear the first 2 clearly. So with regards to SAHPRA and pharmacovigilance centers, so as mentioned, I'm assigned and contracted by Western Cape Health as a pharmacovigilance officer. So my main role is to train and assess causality and preventability of those reactions. So there's not much of a involvement per se in my duties as a pharmacovigilance officer. So the big role that without those reports, so the main role that pharmacists are going to play is identifying and where possible preventing those adverse drug reactions, even though you're reporting them. So your contribution is mostly in reporting as best possible those adverse drug reactions and adverse events following immunization. So in terms, you can involve us. So as mentioned, at the Medicines Information Center, you can call us if you're needing assistance with managing or identifying the adverse drug reaction with a patient. But in terms of work and contribution to the work that's been done, those roles are generally assigned by SAHPRA and by the Department of Health in their positions. As the information is also private and confidential, we do have to sign, confidentiality clauses as well that would give us access to that information when we're assessing those roles. When we're assessing those reactions. I hope that answers that question.
Thank you.
I would like to answer the question on the AMR.
Continue.
Sorry, I just jumped in there. So yes, I am very keen to work with anyone who wants to look at AMR guidelines for the community. You can contact me at the following email address. It's an acronym SAEDP, and that stands for the South African Essential Drugs Program where I work. So it'll be saedp@health.gov.za. So just pop me an email and just put a little bit of an explanation about why you're emailing, and then I'll be in contact.
Thank you so much. Ruth is going to drop that email for us in the chat functionality. We will make sure that the rest that are on YouTube and Facebook somewhere, somehow, get that email address. Thank you so much. Andre has also posted the email address where we can send or when we want to report registered medicine, scheduled medicine, that we find them in this unregistered facility pharmacies. So we'll just call them shops. So that contact is also available there. Ruth, thank you so much. That email is already there. Can I check with the team if there is any more questions?
Ms. Mokoena, I don't think Ruben's question was answered. Are we supposed to report when the side effects are common? For example, a patient taking 2 drugs and gets side effects on both.
So I would always say report, and as mentioned before, so even though it's documented, it may not be well documented or known, and especially if there's multiple drugs being implicated. So the reporting component is not only to confirm an adverse drug reaction with the medicine, but it's also going to contribute to what is the significance. So for an example, with the fluoroquinolones, we've used them for 40 years, and over those 40 years, it's only now in the past 10 to 15 years that we've really established those more serious uncommon adverse drug reactions related sometimes to some of the common reactions, but in the terms of severity and the incidents that they were being reported, it was underreported because often they were seen or viewed as not having serious or any long-term effects. So with regards to, as mentioned, side effects, even if it's documented, it may not be well documented with the other drug. There could be risk factors associated. So again, is there a contribution of the combined use of that drug that has not been notified or documented, that there's increased risks for certain adverse effects that maybe then need to be investigated further?
Thank you so much. I don't think we have any more questions, but safe to say that I don't know about you, but I've just added 3 more CPD interests online. So I'm told also that under the Pharmacy Month page, you will be able to access all these presentations. I think this presentation, all of them were very, very important, I think, across all sectors of pharmacy. And with those few words, I would like to really, really extend a word of appreciation, a thank to each and every one of you that made time to come and listen to us. And special thanks to the speakers and the working group constituted by the Department of Health, ICPA, PSSA, the Pharmacy Council team, for all the hard work. This team has been working very, very hard way before this month to make sure this event very memorable. And I think for me, it was really, really great. With those few words, thank you so much, and have yourself a lovely evening. Thank you.